Hi, welcome. We're so glad that you've joined us today. Today, we're continuing with our six-part series that we're doing on the recommendations for the psychosocial support of NICU parents. Today, we're going to be talking about NICU discharge planning and beyond, what happens when a family goes home. This whole series that we're doing is based on a special supplement that was published in the Journal of Perinatology at the end of 2015. And for this publication, the National Perinatal Association brought together a diverse interdisciplinary team to talk about what were all the things that we needed to do in order to just not provide the best medical care for babies and families in the NICU, but to expand that beyond that and recognize that the emotional support that we offer families as they become parents under incredibly difficult circumstances in the NICU is something that is not just relevant for their own happiness and well-being, but it's also another medically important practice because we know that the more we invest in the well-being of the family, the better the babies do. The supplement that was published had 6 different domains that it covered. So there was a section on family-centered developmental care, peer-to-peer support, the role of NICU mental health professionals. We covered palliative and bereavement care for when a family is facing a loss or a long illness, and NICU discharge planning and NICU staff education and support. We're doing in this series a webinar on each of these 6 different domains, and we invite you to join us for those. But today we're focusing specifically on the recommendations for NICU discharge planning. And again, when we talk about why these are interdisciplinary, when we brought together our team that was going to put together these recommendations, we recognized that the NICU is staffed by a tremendously diverse group of individuals, each with their own specialized care and insight and education that they can contribute. And we knew that in order to come up with guidelines that were truly relevant, that could be implemented NICU-wide, and that would really support families, we knew that they needed to be interdisciplinary guidelines. So when you read these, you'll get the experience and the input of not just medical staff, but also support people, neonatal therapists, social workers, but most importantly, when creating these guidelines, we especially sought the input of families and parents who had had their own NICU experiences, and all the recommendations that we have are informed by that. Our objectives today are to talk about, again, the why is this important and how do we carry it out. So we'll touch upon what it is that makes successful evidence-based NICU discharge planning. I'm your host, Erica Goyer with the National Perinatal Association, and I'm here today with my co-host, Allie Dunn from the Preemie Parent Alliance. Our presenters today will be Heather McInnes and Isabel Purdy. Tell you a little bit about them. Dr. Isabel Purdy is an instructor at the UCLA School of Medicine and also their School of Nursing. She has made tremendous contributions over her last 40 years as a NICU professional and researcher. And really one of the most important contributions that she made was helping to reframe the way that we see vulnerability, especially of these families, and recognizing that vulnerability isn't just a challenge with negative consequences, but it's also a tremendous opportunity for positive interventions and positive change. So we're so grateful to have her here and have her insights as the lead author on this section of the psychosocial recommendations. Our co-presenter is a parent, Heather McInnes, and Heather has worked for several years now as a parent advocate and as an educator for families who are having a NICU experience or going home after one. She also brings with her her own personal experience of caring for and raising her micro preemie. She works for an organization, Graham's Foundation, which has a tremendous preemie parent mentor program that she developed. And she has now continued to go on and expand her role within Graham's Foundation. And we're grateful to have her here today also sharing her unique perspectives. So Dr. Purdy, I guess we should start right at the beginning. Can you tell us what is evidence-based NICU discharge planning? What does it look like?
Well, I think the biggest thing to consider is that discharge planning starts at the beginning. It starts the day that the baby comes into the NICU. So we should really be thinking of supporting, with goals of supporting parents, psychosocial needs, nurturing the parental skills to bond and care for their child, and linking families to community resources and help families being equipped right from the beginning. And I feel that that's one of the most important things that evidence has shown us, that when we start early, discharge planning is going to be more effective. And when we actually look at using individualized care for families so that each family is treated with a open palette of things that we can offer that would be best suited for their family and that would help them absorb what they need to learn at the times that are most appropriate.
I love to. I'm going to turn on my camera for a minute, Dr. Purdy, so I can see you and maybe you can do the same. I was going to say, one of the things that I appreciated so much about it, as you know, the way you broke it up into 4 different domains. So often people think of discharge planning as just being that time that they spend talking to the social worker, taking care of insurance if that's their role, or getting ready for follow-up visits. But like you said, this is something that really begins from day one. So can you tell us a little bit more about each of these domains and what some of the special considerations are?
Sure. Well, the 4 domains that we're mentioning that are showing up here, emotional support is something we can immediately and entirely throughout the whole NICU stay be focused on. And that's helping the NICU parents to really recognize what emotional stresses they have, as well as discussing it with us. And I think this is difficult because a lot of the problem areas stem from poor communication. Many times the data has shown us it's been poor communication between either different units in the hospital that the parents are interacting with, as well as with different opinions of how to manage care, as well as parents feeling not welcomed to be part of daily rounds. And this was something that was very common probably back in the 40s and 50s, when dads weren't even allowed in the NICUs. But today, the goal is to really recognize that parents need to be part of daily rounds, and more hospitals are shifting towards that, as I think we've been trying to address that in the guidelines, as well as limiting visitation policies, that people can only come at certain times, and also restrictive practices about touch, who can touch when and where. The touch restrictions were to really allow babies to have sleep, so that people coming in to draw labs all the time or do x-rays would have to do it around the baby's sleep schedule, but it shouldn't be limiting the parent's schedule.
Yeah.
And then parent education, pre-discharge, that's a very important topic, because we need to find out what is the areas that the family needs the most work with early and all throughout their discharge, and almost making like a roadmap. And some NICUs use a roadmap to let's start off here, and then you can keep seeing where your little car is moving along and how close you're getting. And then the next part is then the follow-up care. So if we successfully do a good job with discharge, it really does help to have that pre-discharge piece really intact. And the follow-up care is going to include that very well-written discharge plan. And it's got to be a plan that's working with both the family and the medical team and the subspecialists who will be following afterwards, so that it's designed to make everyone understand what's going on and to get feedback about what else needs added. And then also follow-up care might include the high-risk follow-up clinics. Many times across the US, there are follow-up clinics for the NICU, and they include neonatal staff as well as physical therapists, neurobehavioral help, and neurodevelopmental assessment and growth planning and evaluation close to the time the baby's leaving, and then scheduling out to follow them through 3 years, which is pretty strong and well supported in many
Yeah.
states.
No, and I
And then
think
on
it's
top of
really,
that, I think,
I'm going to interrupt you for a second, but it all reminds me as you're talking about this continuity of care, a very important quote that was there in the article that we read. And I thought this was especially powerful.
thank you. That one is near and dear to my heart, because it's been something that we've tried to have quality improvement on for many decades. And the easiest thing to do seemed to be to talk to families, share everything, and write it out. And then when the electronic medical record came along, it seemed easier to just put everything in the electronic medical record. And yet it doesn't quite tie in some of the pieces that it needs to
Yeah.
by putting it only in the medical record. So definitely the handing somebody a list of items as they're leaving with already an overbulging list in their head of all the things they need to be doing and remembering is helpful in some ways, but we really need to make sure that it doesn't just end up lost in a file somewhere. And we need to make sure that all of the scheduled people we're expecting the family to take their child to, that they're aware of it and that an appointment is booked. If the appointment isn't booked, they forget it. And also many clinics sound like the same clinic. Oh, I might be going to a pulmonary clinic, and then what is it, cardiology, and now I have to go to ENT. There's a whole, many complex patients have a lot of specialists to see afterwards. So I think that it is, you're correct. It's, jeopardizing babies, and it's not in their best interest. And the American Association of Pediatrics has emphasized that as well, in hopes that our goals and that our quality improvement measures will show that families got out the door safely. But then during that first week that they're home, they also have a contact person from the discharge team who they can call back and say, I have another question. What do I, who can help me with this question?
Oh,
And
yeah.
that helps a lot, because many times the discharge coordinators at the hospital can fix that question, help with financial, and help get the referral straightened out and decrease stress.
Well, that's why one of the things I love so much about what you do and what you started to talk about with us was the role of the developmental follow-up clinic. And I thought it was interesting as we were talking, you told me that, in one clinic, what's typical for there, but then you told me about another clinic that you work in that's actually in more of a rural area, maybe more where families are more isolated. And you mentioned the important role that visitation has for those families. So can you tell us more too about, how does that bridge the gap?
Okay, so for regional hospitals, many times we have connections with rural locations that need to get their child sent over really quick to a higher level of care. That means when they go home, they're going to be very far away from us. So it might not be as easy for them to come back as often to see all of the subspecialists they need to see once they're discharged. So some sites actually have home visitation when you go home. Right as you walk out the door, you already know, or you may have met that home visitation nurse before you even leave the hospital. Some locations back east even have it set up through funding where the nurse or home visitor is part of the OB team. So they may have had OB consults with a home visitation before the baby was even born. And then that kind of continuity is really great, because the parents feel like there's a connection from pre-delivery to the NICU, and they're welcome to come into the NICUs to find out what else is going on before the baby goes home. And then that gives the parent a chance to ask questions and have another person who's going to be out in the home with them who can help with that. So I think the home visitation is a great idea. I hope we keep finding ways to find more funding for it. But yes, a clinic that I work with that originally is a telehealth clinic out in a mountainous area of high desert, that clinic has the need for and utilizes lactation support, care coordination support, access to growth and social needs through home visitors. And those home visitors actually get people into clinics earlier, and they get them back to the ER if they need to be there. And they can call into the high-risk follow-up programs and say, we're seeing this baby losing weight and we're very concerned, and we can just add on an extra quick visit to make sure that it is appropriate or make changes to the nutrition.
Yeah, I love it. I know that I benefited from having a home visiting nurse who came within the first, I forget if it was 24 or 48 hours
Oh,
after.
that's great.
And it made such a difference. And we know that this is a standard of care in other countries. We know it's the best practice. And yet here, you're lucky if you have a home visiting program, the nurse family partnership or something like that in your community. But boy, I would love to see it spread. I think it's really is the gold standard when it comes to transition.
I agree. I think it should be the gold standard, and it, of course, some of our locations are not in the outback like in Australia where they utilize it really nicely. We're not even that far away, but a 2 to 3 hour drive for some of our patients one way means a 2 to 3 hour drive back home as well, and that can be very challenging with children that are special health needs with a lot of equipment too. So it does ante up the stress for the family, and if there's a way around it that we can help make it better by including home visitation, consolidating clinic visits where 2 or 3 visits can be handled on a day. And I think the future is going to be using telehealth for some of those visits. If we don't have to see you in person, but we can see you and your baby, and we can identify what we need to from, a distance, and then save the big visits for, when it's a really important visit that something's going on or that we just see you more often by telehealth.
No, I think it's so important, and it speaks to two of the things that we talk about with evidence-based NICU discharge planning, which is the relationship that you have, and hopefully it's one that's carried you through, maybe part of your NICU stay into the transition, but also that continuity of always being connected with somebody who knows what's going on and can follow you when you've left the NICU, especially for families who may have been, we know how many families are, their child is transferred to a NICU that's far from home. So.
And I think the important part of that too is that with a home visitor, you have somebody who's physically there and can be there and develops a bond with the family, and this is a trust that becomes really important. So when something goes wrong, they know to get help right away, and they act as a whole care coordination team with the community.
Right, and they know who to go to. So we've had this wonderful conversation with Dr. Purdy. Now let's talk more about what the parent perspective is. So Allie and Heather, tell us more.
Heather, tell us your thoughts on the discharge process in general, what it is like for a parent, and why were you a part of the development team?
I delivered my first baby at 25 weeks, and we spent 75 days in the NICU during Owen's growth those first several months. And walking out of the NICU doors was incredibly overwhelming for us. I was a first-time mom. I had never cared for my baby by myself. I had an amazing team of staff, nurses and doctors, and they really became a family throughout our stay. So when we were walking out the door and it hit me that I am going to be the primary caregiver of this medically fragile little person who wasn't even 5 pounds yet, it was just as overwhelming and terrifying as it was a joyful experience. And they did the best that they could. Our medical staff did a great job trying to prepare us from their perspective. I had CPR training, we did rooming in, things like that, but I didn't feel confident in my abilities as a mother at that point in time to be able to take over caregiving 100%. So I think developing these guidelines and utilizing the input of veteran parents, it's a wonderful step in the right direction. I mean, opening up those lines of communication and building the confidence so parents feel ready when they leave, and they're feeling confident in their role as parents.
Absolutely. As a graduate NICU parent and a current NICU parent professional, can you share your perspective on parent experience as well as your own with regards to discharge planning?
From my personal experience, when we were preparing to bring Owen home, the discharge planning in the NICU was focused primarily on the steps that Owen had to take in order to be ready to leave. Like I said, we went through CPR training and they let us room in for a night, which was incredibly invaluable. Those 15 hours that I was in charge of my baby before we walked out the door with the nurses being right down the hall did help considerably in preparing me to feel ready to take Owen home. They were both really helpful, but it didn't fully prepare me for what I was getting myself into. Like I said, we have this wonderful cushion of amazing medical doctors and nurses that if anything happened, I could turn to them and say, what is happening right now? Help me. And I didn't have that once I left. So, the parents that I've talked to over the years, a lot of them haven't heard of early intervention upon discharge, or their NICU follow-up appointments weren't made before they left. Some of their specialists, like we talked about before, the importance of discharge planning when it comes to having that list of, I walked out with a list of places I needed to call, but I had a person that I needed to take care of, and prioritizing what came first, nursing and pumping versus making those phone calls and how to juggle it together was really challenging. So, having the ability to have a partnership with your medical team so that you feel supported and that you're not alone as you're walking out those NICU doors, even that you're going home feeling like you're prepared. Beyond developmental follow-up care, it's just really important to prepare parents for that next step, what those next weeks and months are really going to look like as they're transitioning home with their child.
So thank you so much, Heather. I mean, I think you paint a perfect snapshot of what it's like to try to go home. And like you said, you now have this baby. You've been in this like incredibly intensive medical environment, and now you're at home and you're the primary caregiver. And like you said, it's like, am I going to feed my baby or am I going to make these phone calls? And you can end up feeling, I think, as if you can't do everything. And that can cause a lot of emotional stress. So this leads to a question I have for you, Dr. Purdy, which is, what can NICU staff do in way of offering anticipatory guidance, especially about what this feels like to go home?
This is a very important question, and it's one that I think really encourages us to talk to the families and find out what for each of them are things they feel that are completed and well understood, or items that maybe we need to focus on more to help them be better prepared at time of discharge. So sometimes going through the discharge list with families and what is it going to look like, as you were saying, in the next couple of months, that's really vital, because you want them to walk out the door knowing that what they're expected to do and what their child needs from them is something that they're going to feel comfortable doing, or they're not going to feel comfortable doing. And some of those things they don't feel comfortable doing, then we need to identify how we can educate or provide services that may be able to be helpful. So if it's a G-tube and the G-tube falls out and they don't feel like they are going to be equipped to do that, we need to let them know that they can go to the nearest ER. And sometimes that is a good place to go, or identify ahead of time if the ER that's closest to them is one that would actually put a G-tube back in for a little baby if it fell out. And if not, let them know that they can also return to the NICU clinic or the GI clinic, one of the clinics they're going to, and how to handle that. So I think how to handle not necessarily barriers, but definitely challenges that might occur in the home are really important, including CPR. So for some patients, we might think, oh, really being comfortable and doing a great job with CPR is really for the parents that are going to take home a child that's very, very complicated, that has a lot of complex special health needs. But, recently I had talked to a dad, and his child was a late preterm baby, had a twin, and had left the hospital, and just all of a sudden had been gasping and couldn't take a breath. And this dad had to, while one was calling for 911, he had to literally start CPR, and he did it after just the little bit of training you get in the NICU, and he did it very successfully, and it saved the baby's life. And that baby ended up then being restarted on oxygen before he left the clinic and after the ER. So I think that trying to prepare, when we do prepare for CPR, I don't know that everyone thinks, I'm probably never going to have to use this. I hope I don't. But and I have to say, I feel that way even every time I take a CPR adult class. I think, oh, I hope I'll be strong enough to do this. I don't know if I will, but if you don't have the training, you have nowhere to go. So even if you do it wrong and you're trying to do the best you can, it's better than nothing.
Yeah.
And I think it helps the families feel like they didn't just stand there and do nothing. Also, caring for themselves, I think that is a very important thing. So many times when everybody is the caretaker who is taking care of the rest of the family and not themselves, that population of caretakers tends to, be very stressed, get sick earlier, and get depressed even. So that's something we need to let families know. I think that talking about depression and being overwhelmed prior to leaving the hospital is also something that we really need to prepare parents for. It might be before you're going in, you have a schedule, now you're at home all alone with the baby. The baby's crying, is colicky, or just you're not sure what's going on. And let's face it, the families are not getting enough sleep. So they're exhausted all the time. So when I'm exhausted, of course I get cranky. I'm sure most people do. And you're just not thinking through things as easily as when you get enough rest. So talking about ways with the family that if two family members are working, or if there's a family member that's available, is really one way to help overcome a big obstacle, which is lack of sleep, even though that doesn't seem like the biggest one. And then financial concerns are also a very big issue. So I think talking to families about that, it seems like nobody wants to talk about money. Yeah. But in reality, the dad, the mom, the family is thinking about how I'm going to pay for this. You're sending me to all these subspecialists and referrals. Is it covered? And that's something that we have to focus on and spend some time on as well. From the day they get there, make sure their insurance is there. Make sure that if they change insurance at the beginning of the year or as policies change, that they need to let the providers know, and they need to identify if the providers they're seeing accept that insurance, because then that becomes a whole job for a family that has a sick child at home. And being able to be referred back to a financial person, or again, care coordination in the NICU. Many times NICUs encourage the families, call back. If you have a question, call back, and they mean it. And sometimes a call like that can answer a question quickly and get them to the right person without it becoming overwhelming.
No, I think I'm so glad you brought that up. And I mean, several of the things you brought up, but I know that one of the things we'll want to invite you back in the future to talk about is we do want to talk about the financial aspects of care coordination and everything else. But also, Heather, I'm going to surprise you with a question, and Allie, you too, actually. But I'm going to let you speak to whichever of these is something you want to talk about. But Heather, you first, how did you feel you got enough anticipatory guidance? What were the things that surprised you? Were those things the logistics of it all? Were they the emotional things? How was it that you, if there'd been something you felt you could have been prepared for that you weren't, and when you now work with other parents, what do you talk about?
All of it. You pretty much, everything Dr. Purdy said hits the nail on the head. I think maternal health, mental health is a huge thing that isn't talked about enough. And when you are sleep deprived, which is inevitable, and my personal experience, I was trying to teach my child how to breastfeed, and then I would pump and we would bottle, and every time we fed him, it was an hour and a half, and I slept for 45 minutes, and we did it again. So the lack of sleep, I just would love to see more parent support. So we talk about everything that our baby needs, and it's just now becoming a conversation topic to discuss what mom needs as she's becoming the primary caregiver of this baby. Any other children still doing everything that she did before this medically fragile child came home. So I think I came home very unprepared for, yeah, all of it.
And Allie?
I have to agree. I didn't even have an opportunity to room in with my babies before they came home. And one of my babies came home first, and then I had a 10-day time when I had a baby at home that I needed to care for and pump and do all those things, and then I had a baby still in the hospital. So that was probably the worst time, because as much as I wanted to be home with my baby, I was so happy that the baby was finally home, but I also felt guilty and I was torn emotionally because I had another baby still in the hospital. So having to juggle that schedule. So I would say, yes, Heather's right. All of it. I was unprepared for all of it.
As if one could ever be prepared for any of this, really. But I mean, I'm so grateful for what you do, Heather, and that we have so many. And Allie, you know, have these parents who have had an experience and are able to take not just the good things that happen and share them, but also to identify some of those things that they think other parents need. And the work that peer mentors and peer support do is just phenomenal. And I think the way you support the discharge process is amazing. And thank you for doing that. So as we start to wrap up, you know, we kind of talk about this like if you had a magic wand, but you know, Heather, I want to ask you first, you know, having had your experience and then, you know, knowing about the recommendations and working with other families, what sort of changes have you seen since your NICU stay or since the recommendations were published? And if you did have that magic wand, what would you like to see? What would you like to see happening, and what are you doing to make it happen?
Such a big question.
I know.
I think since the guidelines were implemented, I mean, my NICU journey was 9 years ago. My micropreemie is 9 now. And so things are so different than they were back then. I mean, really the focus was entirely on the baby. And there's been a great movement towards integrating the family into the entire NICU process. And I mean, just doing cartwheels over here because it's so necessary. It's been proven to build so much confidence in parents. And so, you know, I would love to see more information about maternal mental health, which is definitely something that's been a huge focus in the last year or so. And more connections to a community of parents who have been through the NICU journey and are transition, and they're on the other side of it. There's something so valuable of being able to talk to another mother or father who has been through this process before. It's like you have joined this club that nobody really wanted to be a part of, but once you find out another mom or dad that has this similar experience, it's like we could talk for hours because they know what it's like. It's hard to understand it unless you've lived through it. You know, talking about shared experiences and sharing those stories. And then obviously more ease in getting referrals for the services and resources that parents are in need of. You know, we touch on financial needs, mental health needs, just caregiver needs. I mean, we focus so much on baby, and that, you know, mom's focused so much on baby, and so is dad. And, you know, people start losing focus on mom and dad and how trying and exhausting this whole process can be for them as well. So trying to build a more empowered parent is really one of the things I'd love to see happen more. And you know, the wave has started. It's definitely a great start towards that goal.
Yeah, no, thank you so much. And no doubt. And I think, you know, you've said a couple of times, and I just kept thinking about how often parents, even mothers, don't take care of themselves. the mother may have just experienced a traumatic birth also, and yet how often it is that you set all that aside because you now have this person who's depending on you, this baby who's depending on you. So I appreciate you so much talking about those things. Thank you. So, and so Dr. Purdy, as you know, we wrap up, I want to ask you the same question. You know, what are the things that you would like to see happen? What are the things that are happening that you think are very exciting, but where are the gaps still?
Well, I do think what is very exciting, and that's been over a decade in progress, and I think probably even further than that, but definitely Dr. Hyman's work with trying to get more recognition for the fathers is important, as well as the recognition for the need for mental health, psychological support in the NICU by licensed professionals, and having that available for parents so that they are able to feel a sense of not just secretiveness, but when you're in the NICU and you're a nurse and you're working with a parent who has an issue, there's some, or a doctor, and the parent might feel like they don't want to, or can't feel like they can open up because they'll be judged.
Yes.
To the medical staff teams. And having somebody who is separate from that is really important. And if it starts in the NICU, which we've had it happen over the past, I'd say 5 years or more, where we've had psychologists who are available who do family meetings that do not have staff at them, and then also have the staff, you know, parent meetings as well, where there's an intermix, but predominantly it's helping them, families, to hear what other families are. It can be joined families at the psychology meeting, as well as individual meetings. And the team that works with that is also now advancing it into the high-risk infant follow-up. So I had invited them to come join us because they said sometimes, you know, the families already know you, and they're very open to when they see you. You walk in and they're like, oh my gosh, I remember you. And it's better, but it's not totally better. And so they remind them that, yes, you know, we're also available in our family support. Some of that family support also goes out to the home as well. And it's the psychology group coming out and helping families within the home to work through the stresses that they're dealing with. So that, you know, from 43 years ago to now, I think that's a huge, huge area, because I can remember my father-in-law saying that he wasn't allowed in the NICU when his baby was born, and he had a baby born extremely premature back in 1949. Yeah. So, yeah, it's sad that it's taken that long, but definitely the idea of how do we identify, how do we get people to feel comfortable? I think the movement for that has been improving. I don't know if it's across all institutions, but certainly I'm seeing it here and hearing it from other institutions, and getting the feedback from the families that it's very valuable and helpful. And I think if it's a standard of care, then there's less of a stigma. You know, if I know that I'm going somewhere and part of my care involves somebody asking, gee, how are you doing? Do you see, you're, you know, it's okay to be sad. You have this situation. And even then, I think it's hard for us to talk about it. But from personal experience, I've had that happen with illness where I was offered that. And as soon as I opened up, it was like, you know, a bursting of everything, and then all of a sudden everything's better. So it works so much to be able to talk about it and find ways to get through it. I think in the future, you know, what do I want to see? I definitely would like to see more of that, absolutely, at our center, and I think it's moving towards that. Families at discharge rounds and families at the you know, the morning rounds is really should be acceptable. That is, you know, there's no reason. And also it's very helpful because then your feedback about what you're concerned about what your babies are doing, or how you're going to handle getting one home and having one back in the hospital still. That feedback is at the bedside when everybody's there as a team, helps really get your questions answered and helps a plan be established that's workable for you.
Yeah.
And then also importantly, being able to help dads have that position of feeling like they're not just out there taking care of work and, running back and forth, but they are an integral part of the child's startup right from the beginning. So dad's doing skin on skin care, dad's being able to, help do little baby massage, dad's choosing music that they would like to bring in that's within, tones of what would be beneficial to the baby. Talking and reading. Everyone should be encouraged to do talking and reading, because some families don't talk very much. And that's a really huge benefit to the baby's future language.
Yeah.
And it's something you can do quietly at the bedside. Also, I think what I'd like to see more is that the families can help kind of drive, have some way of saying things that they feel they need, just without it being a big discussion. They could, if families could come up with checklists of something that could be at the bedside, I think it being driven by a family support group would be great. Ask me if I'm ready for this, or this, and think of ways that would work for families that maybe we don't think of, because we're busy trying to stamp out disease and save lives and try to adjust to all the new equipment that continuously comes out. What do you think?
Again, as we wrap up, I think this conversation it brings up so much. And one of the things is, again, the focus moving away from just saving the baby and medically, but to restoring a family to where they should be. I also know, we've all had conversations about it. And, Dr. Purdy, you and I were talking yesterday about how often when somebody knows that you work in this domain or that you've had an experience, how much it means to them to be able. I know when my first son was born, and he died soon after his birth, that I had so many women who were my mother's age and my grandmother's age coming and telling me about their stories and what had happened. And like you said, that continuity between what things looked like 50, 60 years ago and in our first NICUs to how things have evolved. Just, you mentioned Dr. Mike Heinen talking about the importance of fathers and the rest of the family, and how much change we really have seen happen. And it makes me hopeful too that we'll continue to make those advances, and that maybe the next, Dr. Hall and Dr. Heinen have both said that they think the next big frontier in the advances of care is not going to be a new invention like an incubator or a new technology like surfactant, but it is going to be the recognizing the power and the healing potential of a family and a healthy family unit. And so thank you so much for joining us for this discussion today. Thanks. Thanks, Sally. Thanks, Heather. Thanks, Dr. Purdy.
Thank you.
So I hope that you've enjoyed the time that you've spent with us today at this webinar. Again, I encourage you to learn more about the recommendations and to find out more about what's in them, and listen to some of the other conversations we're having about the other topics like palliative and bereavement care, or the role of mental health professionals that Dr. Purdy started to talk about. One of the resources we really want you to know about is, out of these interdisciplinary recommendations, they were published and we got such great response, and yet then it became, well, what's the next step? And it really is educating staff about how to start to think about these psychosocial supports, because it's not something they've necessarily been taught. So I'd like you to take the opportunity to go and check out my NICU network. My NICU network is a collaboration between the National Perinatal Association, the Preemie Parent Alliance, and Patient Family Care to develop these courses that talk about the importance of psychosocial support and that bring in parents as instructors for NICU staff to share their experiences and to give examples of what has gone well and what could be even better in the way we deliver NICU care and support. We've talked about some resources today. I also want to point you to, there's a companion website to the publication in the Journal of Perinatology that is support for NICU parents. If you go there, you're going to find resources for both families and for NICU staff and providers to help you start to bring some of these better practices and best practices into your NICU. Of course, the National Perinatal Association and the Preemie Parent Alliance, we partner to bring you this webinar series. We are joined together in a mission to empower and educate family advocates so that they can play an integral role in interdisciplinary care. Heather, again, today is from a fantastic organization called Graham's Foundation. We invite you to visit their website and to find out about the supports they offer. One of the really cool things that Graham's Foundation has taken up is the promotion and continued development of the My Preemie app. If you don't know about this, you may want to. This is a very, very thoughtfully put together tool that parents can access and use on their phones to document their NICU journey, to make notes, to think about things that they might want to talk about with their care team. But more importantly, it plays this incredible fundamental role in helping families find a positive context in which to put their NICU experience and to enjoy their babies and to become a family in a way that, you know, Dr. Purdy mentioned, you know, from day one. It's important that we start preparing ourselves and talking about this important role that we play to these vulnerable babies. Family Advocacy Network, again, we partner with PPA. I want to tell you a little bit about what PPA has coming up. So the Preemie Parent Alliance every year holds a summit, and it brings together NICU leaders, parent leaders, but also people in practice, people in clinics who provide care, or people who are working in the industries that support NICUs and NICU families. So they're having their summit this year. It's going to be the end of September in Denver, Colorado. And if you are at all interested in advocacy and creating reliable systems of parent support for NICU families, we really invite you to find out more about the Preemie Parent Alliance. Our two presenters today have been incredibly generous with their time. We're so grateful, but they also have offered something more, which is that if you'd like to continue the conversation, if you have questions for them or things that you'd like to know more about, they've both provided their email addresses, and you can consider them both, as I have, just wonderful resources for talking about issues around supporting NICU families. We also invite you to visit our companion website to this series. So here you'll find not just today's webinar and some of the resources we talked about, but you'll find the other webinars in this series along with those resources. We hope it's something that you'll be able to come back to over and over again as you look for the tools that you need to support NICU parents and families and babies. Thank you so much for being here with us today. If you have ideas about this webinar series or other topics we can do, if you are interested in getting more involved in advocacy, please reach out to myself, Erica, or to my colleague, Kira, at Preemie Parent Alliance. We'd love to continue to grow and expand this community. So thank you so much for everything you do every day to support families. And thank you for being a part of this presentation.